Hello and welcome to your blood administration lecture by me, Miss Gilbert, for RNSG 1036. The two standards that are for this course related to blood transfusion are the steps of administration and prioritizing nursing responsibilities during the transfusion therapy. Now, first let's talk about blood components, responsibilities, types, and indications. Responsibilities prior to a transfusion. The client has to be prepared. The client has to be prepared for the transfusion. The blood product administration procedures needs to be implemented by the nurse. Agency policies and procedures, the nurse has to be aware of. The provider's prescription has to be in place and on the chart. The client has to be typed and cross-matched every 72 hours. And we're going to use wide tubing or straight tubing sets that we can use for blood component infusions. A blood filter may be used in the administration set to transfuse most, but not all products are require a filter. And we're only going to use normal saline to administer blood products because LR and D5W can cause clotting or hemolysis of the blood cells. We never want to add or infuse drugs with our blood products as they can clot the blood transfusion. And we're going to examine the blood bag, the tag, and requisition slip to ensure ABO and RH blood types are compatible with the client. We'll talk about how to determine this in a moment. And we're going to then check the expiration date and then inspect the product for any discoloration, gas bubbles, or cloudiness, which may indicate bacterial growth or hemolysis in the specimen. If this is the case, take it back to blood bank. Do not infuse. Joint Commission's National Patient Safety Goals. So we need to determine that the blood component delivered to the client is the correct component and that the identification of the client is correct. So how are we determining that these are both correct, that the component is correct and the client is correct? We also need to make sure that we have a provider's prescription, that we have verified it with another RN to determine the client's identity and whether the hospital ID band name and number, the MRN number, are identical to the ones on the component blood tag. So the client's room number is not an acceptable form of ID. We're going to go through a scenario of this hopefully during class the first week. If not, we'll demonstrate the second week. The nurse who infuses the blood product must also be one of the two professionals comparing the client's ID with the information on the blood component bag. So this is not just your facility's requirement. This is Joint Commission's National Patient Safety Goals requirement. You cannot skip these, okay? Patient safety. Now, types of blood components that we can transfuse. We have packed red blood cells, washed red blood cells, pooled platelets, single donor platelets, fresh fluorescent plasma, and white blood cells. They come in different volumes and can be infused over different times. The most common ones that we're going to look at and refer to are the red blood cells, the packed red blood cells. So look at 2 to 4 hours, because this is also what we're going to determine if our tubing is too old and things like that, okay? Because it's the longest time frame, so that's the one that we're usually referring to for our maximum use. Now, our indications are going to be related to what we're giving. Why would a client need red blood cells? Because they're anemic. Their hemoglobin is low, or that their hemoglobin is not that severely low. It's not less than 6, but their symptoms, they're pale, they're diaphoretic, or they're actively bleeding out. They need red blood cells to carry oxygen, right? So looking at their hemoglobin levels is going to be important for our red blood cells. Usually less than 7 at the hospital, we're going to transfuse. Your book here says 6. So anywhere from 6 to 10 is considered a risk if we don't infuse them, but less than 6 is a high risk of mortality. Washed red blood cells, the reason that these are washed in the sense that they don't have as many white blood cells. So yes, we're giving them packed red blood cells. However, some white cells can get in there. But with the washed red blood cells, we're washing out and filtering out additionally after we've obtained the red blood cells. We're going through another step and washing out any of those white cells that may have gotten in there. This is usually because a client has had a red blood cell transfusion in the past and had an allergic reaction. The allergic reaction is an immune response, right? So white blood cells to white blood cells. Clients that have also had a hematopoietic stem cell transplant are one of these types of clients that have the immune issue. So this is usually rare. I've never seen this required in a client in the real life, but it is a possibility that we can do. Pooled platelets, which is our normal bag of platelets, is going to usually a rapid infusion, 15-30 minutes, and because they need platelets. So the condition that you need platelets for low platelets is thrombocytopenia. So our platelet level that we're looking at is less than 20, or that they are actively bleeding and they have less than 50, because they're quickly going to get to below 20 and we can't stop the bleeding. So we're going to go ahead and transfuse them. Single donor platelets are usually those clients that have a history of a febrile or allergic reaction, again. So a rarity in itself is, again. Fresh frozen plasma is usually also rapid infusion, 15 to 30 minutes. They are then deficient of coagulation factors. They need coag factors in order to clot. So fresh frozen plasma has a lot of those coagulation factors. And so usually they also get a bag of platelets, but plasma in itself, FFP, also can help with clotting. So we're going to look at their PT or PTT time. And if it's 1.5 times normal, which is what we want it to be, the expected normal. So someone's expected normal can be different from someone else's expected normal. Like my normal is normal, whereas someone who's on Coumadin, their normal would be high for me, but we want theirs to be thin, right? So their normal is a different normal. So that's why this different expected normal is a clarification here. But if it's 1.5 times what their expected normal is going to be, then they may need some clotting factors, and therefore we are giving them FFP. And then white blood cells. We can transfuse white blood cells if someone is septic or has a neutropenic infection and they are not responding to antibiotic therapy. So this may be a route that the infectious disease doctor may go. Transfusions, steps and precautions of transfusion. So before, we're going to look at lab values. Why are we giving this? Does our lab value match our prescription with the product? So if we're transfusing platelets, are our platelets low? Why are we giving platelets and not hemoglobin if our hemoglobin's low? Or should we be giving both? Or we're going to use it to verify all of our reasons, right? So our prescription needs to have the type of the product, the dose, and the transfusion time. We're also going to need to get vital signs before, know their normal urine output, take note of their skin color and history of any transfusion reactions prior in their history to determine a baseline for our client, as well as to determine if the client can tolerate this transfusion. If they already have a poor urine output, they already have unstable vital signs, this may be a rocky road for them. We want to get an IV access to a central vein, but that's not always likely. So we're going to need at least a 19 gauge is what your textbook uses, but we don't really use odd numbers. So usually it's a 20 gauge in real life. 20 gauge IV peripheral catheter. We want that large bore access so that it prevents the cells being occluded and hemolysis of breaking up in the catheter during the transfusion, because we want the full cells in there. That's why they need them. And then we're going to obtain the blood product from the blood bank after we've done all these things and transfuse it as soon as possible after performing all of our checks, of course. The red blood cell transfusion must be completed within 4 hours of removal from the refrigerator. So it's still cold. Remember this. We're still infusing a cold bag. We're not waiting for it to get to room temperature and then start infusing it, and we have 4 hours. From the refrigerator to the patient, we have maximum of 4 hours for red blood cells, okay? We also have to do it with another RN. An RN has to be signed off on it, and one of those RNs has to be the one that stays at the bedside to infuse the bag. You can't swap out both of the check RNs to a different bedside RN to monitor them for that first 15 minutes. It has to be the same, one of the same two. Now, when we're administering the product, we need to use an appropriate filtered tubing to remove any aggregates and possible contaminants. Again, during that demonstration, I'll show you what the filter looks like. We may have to dilute the blood products of normal saline as hemolysis that may occur during the transfusion, but we're only going to use normal saline because other solutions can cause hemolysis as well. Remember, like I said, LR and D5W do not use. We need to remain at the client's bedside for the first 15 minutes minimum, but sometimes 30 minutes, especially if they've had a history of a reaction. We'll increase that to 30 minutes. Most hemolytic reactions occur within the first 50 milliliters of the infusion. So we'll talk about with that demonstration that your 15 minutes doesn't start when you hit start on the pump. It starts when the blood product is entering the client. So if you're gonna let it go through the tubing, you can't start counting your 15 minutes until it's in your client. So some people like to prime it a second time. Prime with water and then prime with the blood product all the way to the tip, not just to the filter. So we'll talk about different mannerisms or preferences, but it's not a preference for when that 15 minutes start. That is the rule, because what you're looking for during that 15 minutes is the hemolytic reaction, which won't occur unless the blood is in the client. Off of my soapbox. Infusion of the product at the prescribed rate is going to be required. We can go faster if they're tolerating it, but usually it's over a certain amount of time ordered. Unless you're in the emergency room, then you just throw it in. We're going to monitor, of course, for fluid overload as a complication related to a rapid infusion, though. We'll talk about that as a complication later. During the procedure, we're also monitoring vital signs and watching and trending those to see if it indicates any type of transfusion reaction. Afterwards, when we are completed, we're going to discontinue the infusion and dispose of the blood product bag and the tubing properly, because bloodborne pathogens can inadvertently be spread through improper disposal. Documentation of the type of product that was used, the product number, volume of infusion, time of the infusion, and any adverse reactions is required. Responsibilities. We need to ask the client during the procedure if they have any, and also education prior to, so that they know to report these things. To report any unusual sensations, such as chills, nausea, shortness of breath, hives, itching, back pain, especially back pain. That's the hemolytic reaction of red blood cells breaking up and getting stuck in the kidneys. Okay. Any change in physical and emotional status, such as a new onset of the joint, back, chest, or abdominal pain. Again, those broken up cells getting clotted somewhere. And feeling unwell or feeling uneasy. We're going to assess their vital signs every 15 minutes after the start of the infusion. If no signs of reaction occur, we can then increase our rate to transfuse 1 unit in 2 hours, depending on the client's cardiac status and facility's policy. We can take vitals every 1 hour then during the transfusion or specified by their agency policy again. Components without large amounts of red blood cells can be infused more quickly. So like we talked about with the FFP and the platelets. Older clients may require a slower rate of infusion though. So their cardiovascular system may get overwhelmed a little bit easier, or severely anemic clients can as well. So taking 2 to 4 units, the full amount of time for each unit of whole blood, red blood cell, or plasma may be required for these older clients. If possible, depending on the severity and the cause of why we're giving them more than 1 unit, if it is possible, wait 2 hours between that infusion, between the first one and the second one, so that, again, overwhelming their cardiovascular system is less likely. We need to also monitor electrolyte imbalances, especially with packed red blood cells, because those cells that are damaged not only release, like we talked about already with the bilirubin, they also release potassium. So hyperkalemia is very common, especially with multiple blood transfusions. So watching for indications of hyperkalemia and signs of hyperkalemia is another indication for the nurse at the bedside to be watching for. It's more likely with frozen or several weeks old blood components, which often in the hospital setting, most blood products have been frozen. And now we'll go into component transfusion, so actually transfusing these products and what that means. So for red blood cell transfusion, red blood cells are given to replace lost cells, usually from trauma, surgery, or a problem that destroys or impairs the red blood cell maturity. So refer back to the anemia lecture that was just prior to this one as to our indications again. So compatibility must be checked carefully for a transfusion to prevent a lethal reaction. So if we have 2 different types of antigens. We have an RH antigen, which gives us the positive or the negative, and then we have an AB and O antigen. Or an AB antigen. You either have an A antigen, a B antigen, an A and a B antigen, or you have none of them. So then you are type O. And then the other type of antigen that we're concerned about is the RH antigen. So do they have an RH antigen? Therefore, they get a positive. And if they don't have an RH antigen, then they get a negative. So really, it's just these 2 different types of antigens that we're really looking at that can cause those lethal types of reactions and cause the hemolysis. These types of antigens are inherited and therefore determine our blood type. If you don't have any of them, then you are type O. You can only receive what you already have. So think about that. You can only receive what you already have. If I am type O, that means I have no AB antigens, right? So what can I receive? If I can only receive what I have and I don't have A and B, I can only therefore receive O, right? If I receive anything more than I already have, my body's going to freak out and attack it. So if I am A, I can only receive A or O because O is neither, right? But I can't receive anything that has a B antigen. If I am positive type recipient, I can receive any positive, but I can also receive any negative, because that means I'm receiving something less than I have, not something more than I have. So I can, as a positive person, I can receive anything positive or negative. Now, in the hospital, we will try to get it as perfect as possible, but I have given blood products that was AB negative to an AB positive client, and had to give education to that client who interrupted us during our bedside checks because they were paying attention, and was like, no, I'm AB positive. Why are you giving me AB negative? And we had to explain what this means to be AB positive. So she did not have a reaction, because it was nothing that she did not already have. It was something less than she already had, but it wasn't going to harm her. So there are other possibilities other than your exact blood type, and understanding what that means in the phrase that I use frequently: you can only receive what you already have, nothing more. So keep that in mind as we go through with ABO compatibility. Platelet transfusion. Platelets can be pulled from as many as 10 donors all into one bag. They don't have to be from the same blood type, so this ABO compatibility does not matter for platelets. But they are fragile and must be infused immediately after being brought into the client's room, so then we have that short time period, 15 to 30 minutes. Special transfusion with a small filter and shorter tubing is usually required because the longer tubing increases the platelet adherence to the lumen and then promotes clot formation, right? So we want to prevent that. We want the client to have the ability to clot, not the tubing. So we need to get it to them as fast as possible. Platelet filter, again, removes those white blood cells from the platelets so that they are less likely to have those febrile reactions, and especially those that are getting multiple transfusions. Vital signs prior to, at 15 minutes, at the start of the infusion, and then at the completion of the transfusion is pretty much going to be standard for all of these types of transfusions. Plasma. Plasma, when we transfuse plasma, is usually to replace blood volume and clotting factors. We're going to infuse FFP, which is fresh frozen plasma, immediately after thawing while the clotting factors are still active. ABO compatibility, though, is required for plasma transfusions, so we need to know blood types and match them, and therefore type and screen them for plasma transfusions. Plasma should also be rapidly infused as fast as the client can tolerate it, generally within a half hour to 1 hour, through that Y-site or a straight filter tubing. White blood cell transfusions, also referred to as granulocytes. These white blood cell surfaces have many antigens that can lead to severe reactions when infused to a client with an immune system that recognizes those antigens. Therefore, these transfusions are very rare, and when done so, they must be done very cautiously. And they may be type and screened for more than just ABO compatibility. They'll run it against a bunch of different antigens. So that, again, they have to find a blood product, a white blood cell product that was from a client that didn't have extra antigens than they have. So then we're dealing with more than just ABO and RH antigens. We're dealing with many other antigens that may have a factor in this reaction. We're going to infuse it very slowly, over 45 minutes to an hour. Agency policies may be more strict because of the high likelihood of reactions in these types of products, and so they may be an hour or more as their minimum. Physicians have to be present in the facility or even on the unit, depending, again, on the agency's policy, but one of those has to be required so that there's immediate backup if something happens. vital signs every 15 minutes during the infusion. This isn't just the first 15 minutes, and if everything's going well, we move on to the hour. This is every 15 minutes for that possibly 2 to 3 hour infusion. They should be spaced 4 to 6 hours apart if they are also getting amphotericin B infusions, which I don't know if you remember from pharmacology, but these types of clients are probably likely to also have gotten these infusions. But we need to separate these because it can hemolyze the cells. This medication also has many side effects that can mask as transfusion reactions. So we definitely want to know if it's a reaction to the medication versus the transfusion, because it changes how we treat it. Now we have autologous blood transfusions. Blood transfusion from their own blood. This is someone has pre-donated their own blood for themselves. This therefore eliminates any compatibility problems because it's theirs and reduces the risk of transmitting any bloodborne diseases, which is very rare nowadays because we do test for more types of diseases than we did in the past, at least I should say. Still, there is a risk for circulatory overload and bacterial transfusion reactions, though. This can be done pre-operative. Use the most common type of autologous blood transfusion. It's the most common because they know that they're undergoing this major surgery. They're going to need, probably have a lot of blood loss, and they may be their religion may be against getting other blood products from other people's bodies, but they can do it for themselves. So they'll pre-do that, or if they have a very rare blood type, rare antigen that they've had reactions in the past, that they may prepare for this before the surgery so that they're not being dumped with blood that they're not going to be very compatible with if they were to have that severe blood loss during surgery. So they'll donate whole blood and they'll separate it into the different components and store it for later use. They usually are able to donate weekly until the prescribed amount is obtained, or if their hemoglobin hematocrit levels still remain normal. So red blood types, again, like I said, and the fresh red blood cells can be then stored for 40 days. So they can donate for, if they're donating once a week, and it can be stored for 40 days prior to the surgery, they get like 4 or 5 donations of whole blood before their surgery, which can be 4 or 5 units that they don't get from someone else. And that potential for reaction or religious backlash and things like that. Acute normovolume hemodilution is client's red blood cell and volume is replaced just prior to surgery. So it's stored at room temperature during the surgery for about 6 hours, and then after the surgery is completed, they give them back their blood volume. The goal for this is to decrease the red blood cell loss during the surgery. So if we know that's a possibility, or if there is the large blood loss, it may, because of the field of view being covered in blood, may deter the outcome negatively. If they have less blood volume circulating, they're going to bleed less, right? Makes sense. They will take the blood from them first and then give it back to them afterwards, and or right at the end of the surgery. However, of course, if they are anemic or have poor kidney function, this is not an option for them. Again, this is a rarity, usually is because of some crazy surgery that they're doing. But again, it's a possibility. Intraoperative autologous transfusion and postoperative blood salvage. Blood is obtained from the operative field, so they suction it up or scoop it up, from the bleeding wound or wherever in a collection device. They filter it and then drain it and transfuse it. Can be used during trauma or surgery with severe blood loss. And then that salvaged blood can be reinfused to that client within 6 hours. Because again, we're at room temperature, so that's our maximum is 6 hours for autologous room temperature blood, 6 hours. So like we have penetrating chest wound, they're bleeding into their lungs, and we put in a chest tube in order to drain all that blood, and they are kicking out blood by the minute into their chest tube. We actually have a device that once the chest tube is full, you can close it up and then turn it over, and it will filter it and infuse as a transfusion of blood from their chest to their body. It's pretty cool. And then now we go into transfusion reactions. We have multiple different types of transfusion reactions. Febrile transfusion reactions, though, occur most often with any anti-white blood cell antibodies that are in the mix, which again can happen in any type of component, I guess is the word. It can develop after multiple transfusions from white blood cell transfusions, of course, and platelet transfusions. Symptoms include chills, tachycardia, fever, hence febrile, hypotension, and tachypnea. In order to prevent this, we can give them the leukocyte-reduced blood, so the washed cells, or a single donor type of component that has been matched with their platelets. These all reduce the risk of reaction. Also, using a filter traps those white blood cells and prevents their infusion into the client. So if you have a filtered tubing, please use the filter tubing. Even if it's not a requirement, it's just a safe rule of thumb. Now we have hemolytic transfusion reactions. This is the common one that most people think of, hemolytic transfusion. So this is due to the blood type or the Rh incompatibility, the ABO and positive and negative antigen antibody complexes that we talked about. These complexes will be formed as a response and destroy the transfused cells, therefore starting the inflammatory response in the vessels of the walls and organs, and can cause a chain reaction and organ failure. So this can be immediate or may not occur until after several units have been transfused, so you may not really know what triggered the initial reaction. The mild reactions, this is more commonly the thing, just like fever and chills. They may not have any other symptoms, but it's still an ABO compatibility issue, so a hemolytic reaction. Now, when it gets to the point of they have headache and chest pain, low back pain, tachycardia, tachypnea, hypotension, hemoglobinuria, so that's the red blood cells in the urine, and a sense of impending doom. That is because the broken up cells clotted and throwing clots into like lungs. So you get those little micro pulmonary embolisms, and they get that sense of impending doom. And you can also have disseminated intravascular coagulation, DIC. So this can occur due to the hemolytic transfusion. So if any of these symptoms are starting to occur, immediately stop your transfusion, flush it, and call the doctor. Make sure that your client is stable first, and don't give them any more of it, but calling the doctor to get orders if you don't already have them. Now, of course, prevention is going to be through performing all of your ABO checks prior to the infusion. That's all we can do. If everyone did their job right for the ABO compatibility, we shouldn't have an ABO compatibility issue. Now we have allergic transfusion reaction. This usually occurs in clients that already have other allergies and severe allergies. So the onset is usually within 24 hours after the transfusion. So this may be at home, but again, they're typically clients that already have severe allergies and know how to recognize and treat them. But if this is the first time, we need education. So symptoms, just like most other allergic reactions, you get the urticaria, itching, bronchospasms, and anaphylaxis. So saving that airway is going to be our key role. We're going to give them antihistamines and anti-inflammatories to stop the inflammatory reaction and bronchospasms that are occurring and get the airway back open. Preventing, we can do by giving them the leukocyte reduced, the washed, and so we're removing any of those issues that may have caused the allergic reaction. Bacterial transfusion reactions, this is due to the infusion of contaminated blood product, especially that has been contaminated with a gram-negative organism. The onset of this reaction is rapid, so as soon as it enters the body is like, hey, that's a bacteria and I hate it, and so it's immediate. Symptoms are going to include tachycardia, hypotension, fever, chills, and symptoms of shock. So we may end up in sepsis. We want to treat by stopping this transfusion, of course, flushing, and giving them an antibiotic as soon as possible once it has been identified that this was the cause. The product is also, and the tubing, going to be sent to the blood bank for diagnostic evaluation to see what type of bacteria started to grow in the component. We can prevent this by looking at your component. Again, for the bubbles, the dark cloudy areas, anything that may indicate something is in there besides the product that it's supposed to be. And then we have transfusion-related acute lung injury called TRALI. This is a life-threatening event that occurs often when donor blood has antibodies against the receiver's neutrophil antigens, HLA, or both. So early recognition is key to this survival. This occurs within 6 hours of the transfusion and has the rapid onset of dyspnea and hypoxia. So this doesn't usually go to the point of like bronchospasm and like angioedema and anaphylaxis type things, but at first it can be difficult to determine the difference between TRALI and the allergic reaction. But they should not have like the itching and urticaria and things like that. But respiratory wise, this one is more focused on just the lungs. These clients may require intubation and mechanical ventilation for respiratory support. So recognizing it early and saving that airway to save their life is going to be key here. Transfusion-associated circulatory overload, also called TACO, or circulatory overload in general. This occurs when blood products are infused too quickly for the client to compensate for, and this is especially more common in older adults. This is may become a pulmonary reaction. It may be too difficult to differentiate from TRALI in these cases. Most common type of reaction with whole blood transfusions or clients receiving multiple packed red blood cell components. And so symptoms are going to look like hypertension, a bounding pulse, distended jugular veins, dyspnea, restlessness, and confusion. Again, remember, they have too much circulatory, too much volume. So you have the circulatory overload, circulatory hypervolemia type symptoms, right? Preventing and treatment, so watching their intake and their output, and infusing the product slowly, and we may need to give them diuretics. Then we have this fun thing. I don't even know why they give it an acronym because you can't pronounce it. Transfusion-associated graft versus host disease. So graft versus host, just like with any transplantation, what's the word? Organ donation. Essentially, you're giving them, it's not an organ, but it's from somebody else's body. So just like how you can reject an organ, you can reject blood. It is rare, but when it does happen, it is life-threatening or can be life-threatening, and usually occurs in clients that are already immunosuppressed when their donor T cell lymphocytes attack the host tissues. So onset is usually within 1 to 2 weeks after transfusion, and 80 to 90% of these clients may die. So these clients may be seen in their doctor's office or emergency room 2 weeks after they've had a transfusion, and if you don't ask just the right question, you may not know why they are having thrombocytopenia, anorexia, nausea, vomiting, chronic hepatitis, weight loss, and recurrent infections. Preventing this, the only way to do this is to irradiate the blood products that they receive in the future to destroy any T cells and cytokine products that may be in the components. Then we have acute pain transfusion reaction. This is rare and the cause is still unknown, but it's typically not life-threatening. It's just more of a quality of life issue. The onset is usually during or shortly after the transfusion. They may have severe chest pain, back pain, or joint pain, but they're not having a hemolytic reaction. So what the heck is going on? We've ruled out all the other causes and reaction type things, but they're still having these issues or temporarily have these issues. They may also have hypertension, anxiety, and redness to the head and neck. So it's not just something that their anxiety is producing. It may be a factor in it, but it's not just psychosomatic. You actually do see these issues on like their body, of like redness to the head and neck. We can give them pain medications and medications to stop with rigors and control or reduce any other symptoms that they're having. But we can diagnose this. It's an expensive test. But rare things are usually expensive to test for anyways. A positive direct antibody test can be done. This is a blood test, and it indicates a degree of hemolysis has occurred to part of the blood, but not widespread. So part of the blood is reacting, but not a triggered reaction to all of the blood reacting. So that's what caused their issue, their pain. So when we encounter a transfusion reaction, like hemolytic, allergic, and bacterial reactions, we're going to stop the transfusion and remove the blood tubing from the body. I cannot tell you how many times, like on TV or just questions on exams or talking about it, that it baffles me. If they're having a reaction to the blood, don't use the blood anymore. So they'll stop the pump, but then start something to the same tubing. So then you're giving them still another 10, 15 milliliters and anything else that's stuck on the lumen for the next 30 minutes to them, re-exposing them to the causative factor of the reaction. So just discontinue it, completely unscrew it from their IV, get a whole new tubing. Do not use the same tubing. Even if you flushed it out, you don't know the little particles that are still stuck on the inside of that lumen. Remember, white blood cells and platelets, they can be sticky, okay? So just don't even use the same tubing. Throw it away. But if it's bacterial, send it to the lab. Don't throw it away. We're going to return the bag, the labels, and all tubing to the blood bank for the bacterial. And sometimes the hemolytic, the physician will ask you to send it down, but not always. We're going to notify the rapid response team, get everybody in there, all hands on deck. Make sure that we still have the patent IV, because that inflammatory response can cause your IV to no longer be patent. It will close it off. So make sure you still have an IV. Keep flushing it. Keep flushing it. Again, don't flush it through the tubing, because you're going to cause more of the reaction to happen to the client. Completely get rid of the tubing. I swear to God, do not flush through the tubing. We're going to be monitoring their vital signs, of course, but we may want to apply oxygen, because if they are having a hemolytic reaction, those blood cells are dying off or lysing, and so then we have less oxygen carrying capacity. So giving them as much oxygen to compensate as possible. We may need to give them some Benadryl, which is diphenhydramine, through an IV push. If a client is going into shock, we can give fluids and may need to do additional hemodynamic monitoring. We need to give blood pressure support if possible with vasopressors. We may need to give antipyretics for any fever, antibiotics if we suspect that it was a bacterial issue, and meperidine, which is Demerol, for any rigors that occurred. So treating essentially any symptom that's going on, right? But these are the common ones. All other types of transfusion reactions, we're just treating, again, the symptoms until it's resolved and preventing any further complications. Some things, like with the allergic one, may just be Benadryl, maybe oxygen. We'll see what happens. But you have that rapid response team at the bedside, so if it hits the fan in 2 minutes, you're not alone. So even if you just have them hang out for the next 15 minutes, safer than sorry. These came from Iggy in chapter 37, as well as ATI chapter 40 for your blood and blood product transfusions. And we'll talk more about this in class. Thanks.